Physical therapy. Welcome to a little addition of some great self-mobilization tools and techniques. Some of these are my favorite. What we're going to be going through today is a combination of some hip capsule, some upper and lower trunk mobs for all kind of those, what we call kind of those train tracks that travel throughout the kinetic chain. It's also what we're going to be going through is a great mob for the scapulothoracic joint, thoracic spine, glenohumeral joint, what we'll call creating some good thoracohumeral and scapulohumeral kind of motion all together. What we'll do is take a super band. So we have it connected to the true stretch right here. You can easily use a fence post. You can easily use a tree branch to be able to do this. I'll typically go about head high, a little bit higher. As you've gathered from me so far amongst kind of our journeys together, you note that, okay, we do a lot of FMR, a lot of functional manual reaction therapy based on solid, fundamental biomechanical principles that are truth with regards to sequencing in function. I try to get my hands off a patient as soon as I can. As good as the manual therapies are in terms of breaking up restrictions, providing proprioceptive feedback, it can also be smothering to a point as well. It's okay to make mistakes. I try to provide my patients an opportunity to replicate the environments that we create throughout our treatment sessions in the clinic throughout the week, so that patients can further, like yourself, can further your progress at home and on your own. The way that we do that and the way that we harness in on that substantial change that we create is through practice and over a period of time. So, relatively speaking, seeing you twice a week for 2 hours total, an hour each treatment session, in retrospect is not very much time throughout that week. We need to be able to create an environment for you that's positive, productive, and that drives and instills those changes that we create within the clinic for you at home, so that short-term and long-term you're making great adjustments with regard to trampolining yourself out of where you were to that transformation that we want to see you, which is getting closer to what your genetic potential is. So what we'll do with the super band, the super band's going to go arm's going to go inside the super band. Super band's going to go just above the elbow. With the other hand, then, I'm going to help kind of guide it on in, so I grab with my right arm. Right arm is going to grab the reins almost like a horse. First thing that I'll do is I will go after kind of some lunges. So I'm going to go after a good just anterior lunge. Go after a good anterior lunge. Left leg lunges on out. Right elbow is pointed right at you, so that as I transition into my lunge, I have an upper extremity posterior reach. Upper extremity posterior reach. What I'll do now is I'll use the opposite side arm as a driver in sync. So I'll go with a little in sync driver here to take the trunk to the right, which will help kind of speed up the pelvis, which is rotating to the right, but to give us more internal rotation also of the right hip to drive some more extension and abduction of that right hip as well, due to the also in collaboration with the posterior reach. Another progression is to go kind of what we'll call this ipsilateral, same side lunge. And what I'll do with this guy right here is I'll add a little out of sync upper extremity driver. I'll go a little out of sync upper extremity driver to open up thoracic spine. So I'm actually kind of getting this type 1 out of sync, this rotation to the right, almost this little side bend to the left due to my right arm being up and overhead. Important to realize on this, the lumbopelvic hip complex typically with regards to the abdominal, we're taught that we need to lay in these supine, these prone positions to target our core, front and back, and most typically kind of the supine position to go after the abdominals. We know, based on an applied functional science approach, that that is incorrect due to the fact that load to explode, we need to take a look at the rectus abdominis, the internal external oblique, transverse abdominis, and see how the pelvis is moving with regards to thoracic spine and the rib cage. We know that they get severely turned on by some frontal plane motion of thoracic spine of the rib cage from the top down, and from the bottom up, frontal plane motion of the pelvis due to what the lower extremity is doing. We know that they're highly responsible for helping to disassociate motion via that speed element and that directional kind of driver of thoracic spine, of rib cage with relation to the pelvis, and the pelvis with relation to the femur, so hip motion. Load to explode, we see that sagittal plane wise, that this continual shortening, this continual kind of flexion of the trunk is not a way to turn on the proprioceptors of those abdominal muscles. We need extension, we need a lot of disassociated rotation, and we need a lot of good disassociated frontal plane motion, top down and bottom up drivers. So after our sagittal plane lunges, something that I'll typically like to do, I like to go anterior lateral with it. So I'm going to go with an anterior lateral kind of lunge right here, and I can really feel in terms of the hip capsule really open up. I can feel the growing on both sides due to the deceleration of the flexion, the extension, due to the kind of what we take a look at in terms of its insertion point on both sides, the AB kind of the deceleration of the abduction right here, as well as kind of the internal rotation of the hips. And I'll also go anterior lateral in the opposite direction. Go anterior lateral, left anterior lateral lunge. And I can go kind of a little in sync kind of driver right here as well, which will kind of further open on up the kind of axillary space via the anterior kind of hip capsule and that anterior chain, which oftentimes really gets super gummy and really gluey. So axillary space, so kind of the armpit region, space of the hip flexor for the upper extremity. It's a big train station in which a lot of train tracks are constantly kind of running and going right on through in terms of a lot of high junction, high concentrated area, kind of junction of tissue. What I'll also do, I'll go with a little anterior medial lunge. I'll go with a little anterior medial lunge right here. Really open up that anterior kind of chain throughout the lower and upper extremity. And I'll go a right-legged anterior medial lunge. And I'll take my upper extremity, my opposite side upper extremity, and I'll drive out of sync. I'll drive out of sync. What I like to do next, I love to go kind of with a little same side frontal plane lunge to really go after the lateral kind of hip complex, lateral trunk complex. And I can use my left upper extremity and go with a little frontal plane, kind of drive her down underneath. I'll also go frontal plane kind of opposite side, frontal plane kind of lateral lunge, kind of sequencing to dig a little higher on up into the lateral trunk. So body-wise, we need to think about how we have these throughout the chain, kind of these anterior oblique subsystems, opposite shoulder to opposite hip, and posterior, opposite shoulder, opposite hip, but then also kind of these ipsilateral patterns that will go from same shoulder to same hip, and these good kind of deep longitudinal kind of structures that will go from kind of the side of the ankle, the bottom of the foot, all the way up through the sides, and then throughout kind of the midline, the medial aspect of the body. So body connective tissue wise, we have basically these grapevine-like structures and train tracks that spiral all throughout the chain from base of the head to the toes. What I also want to do with you, I want to go on opposite side, kind of rotational lunge. So again, with this, I'll use these techniques a lot with my FMR. I'll go after the hips, I'll go after the glenohumeral joint, I'll go after thoracic spine, and I'll go after scapulothoracic joint. This is a way to help kind of assist me as the patient is driving motion, and a great kind of top-down driver to really go after the kinetic chain. So we did an opposite side kind of rotational lunge right here. We went with kind of this posterior anchor for the most of kind of what we were doing. We're next, in kind of the next session, we're going to go on a little bit of an angle for these guys. I believe that the more diagonal we can make things, the more authentic that replicates kind of the true identity of how the body needs and desires to be loaded, so that it can have the opportunity to explode throughout those chaotic, unstable, unpredictable environments three-dimensionally as well. Play around with those.